making a summary of all those discussions and coming up with the resolutions that will take us through the journey of having outcomes that we want to follow up. And that, of course, will be our first issue to look into in the next convention in terms of this is what we made as resolution during this particular conference, and where are we and what has been achieved to that end. So thanks once again and welcome to today's convention. I give it back to the chair to take it up from there.
Thank you so much, Mary. Now we'll go now to today's presentations. We have the first presentation from, about HRH staffing. Dr. Kihama. As Dr. Kihama, yes. You take us through a number of HRH in counties against the staffing norms and the government HRH strategic plans. A round of applause as he comes. Thank you.
Like you've been told, my name is Dr. John Kihama. I'm presenting on the impact of health workers shortage on access, quality, affordability, as determinants of health outcomes. So there was there may have been a slight mix-up. Was only preparing for this topic, which I'll take you through. That's the outline of the layout of the presentations. We have an introduction. We look at the health system. To remove my mask so that I can be a bit better heard. Then we look at the health workforce, the shortages, effects of health workforce, worker shortages, and addressing them, and strategies for restoring health workers, health care workforce. So the healthcare system's ability to provide high quality, effective, and patient-centered services, and ultimately achieving universal health coverage depends on sufficient, well-motivated, appropriately skilled personnel operating within health systems that optimize their performance. So that's a statement that's carrying so many things and so many facts that we need a health system that's working. We need the workers to have the equipment. We need them to have the right working environment. We need them to be very well motivated so that even if they are available and they are performing, their performance can be even better. Good. We were looking at the health systems. When we talk about the health systems, I think most of us may be familiar with the World Health Organization health system building blocks, right from service delivery, the health information systems. Then we have the products and technologies, that's the medicines and the equipment. Then there is also the building block on financing and the one on leadership. I've left the one on health workforce to mention last, which is one of the most important systems, building blocks in that system. So the health system building blocks, there are those which are cross-cutting, and these provide the basis for overall policy and regulation of all the other building blocks. Like the leadership is cross-cutting, and in case of its failure, all the others may not perform optimally. Then we have the health information systems. It provides information for all the other building blocks. We have the key inputs, that's the financing and health workforce. And then we have the medical products and technologies. So without those inputs, the system would also not be operating. Then the other building block is the service delivery, which is the immediate output and depends on what has been put in terms of all the other building blocks. Then we come to the health workforce. So the health care sector is labor intensive, and human resources represent the most important inputs into the provision of healthcare, as well as the largest proportion of healthcare expenditure. The numbers of health workers in the system depend on the population needs, health needs, the trends in the health service utilization, production, among many other factors. So what's important here is to note the health sector is about offering service. And where you are offering service, you need human resource. And where you have a very big proportion of human resource, your budget will also be largely covering that health human resource. So in the health sector is labor intensive. We have a lot of everything is being done by the health workers, and like we have said, it consumes the largest part of the budget in that sector. What's the next one? I'm having some challenges with the technology. Just bear with me. Somebody assist. So you are there. So in terms of looking at the instruments that are supporting the issues to do with health workforce, We have the Kenya Health Policy 2014 to 2030, and it aims to have adequate and equitable distribution of human resources for health. So the issue of the health workers, the health workforce is well captured in the Kenya Health Policy 2014 to 2030. Then we have the Kenya Human Resources for Health Strategic Plan 2019 to 2023. And it aims to see that the country has the capacity to produce, it states that the country has the capacity to produce about 51,000 nurses, doctors, and clinical officers combined by 2023. So you can see we have the capacity to produce workers. We have a health system that's growing. We have a population that's growing. So the only problems would probably come with issues that we'll see as we move along. Then strengthening the health workforce through policy, adequate financing, planning and recruitment, training and deployment. And retention is paramount to ensuring everyone has access to qualified health worker. So like in the above statement, we have said, we can produce so many workers, but we need to get them recruited into the system. When they are recruited, we need to get them retained there so that they continue offering service. And even when they are there, we need to get them in the right numbers and in the right places so that they can offer services where they are required by the citizens. So health workforce worker shortages could be because of a deficient health education infrastructure. So if we don't have enough training institutions, we may not have enough health workers. If we don't have adequate budget set aside to employ or to carry out recruitment for health workers, we will not have enough health workers. If we have capping by the government or what we are calling the ceilings that have been placed there to prevent employment of more health workers, we will not have enough because the capping does not mean we have enough workers. It's just because we don't have enough budgetary allocation to cater for the employment of health workers. Then we have the global demand for health workers. It also brings out a shortage because if we have workers here who are not employed or who are even in employment and they are not feeling very comfortable where they are and very well motivated, then they'll move and that will create a shortage because they leave gaps in the positions that they vacate. So some countries also face the paradox of health worker unemployment coexisting with major unmet health needs. And I think that's somehow where we in Kenya are. We have a good number of training institutions that are bringing out very good numbers of health workers. But in the face of the capping for employment, saying we cannot go beyond a certain budget for employing health workers. It means we have health workers who are unemployed, but when you go to the system, it cannot meet the needs of the citizens because there is a shortage of health workforce in the health workforce. And WHO estimates that a projected shortfall of 18 million health workers by 2030, and mostly in low and lower middle income countries. So despite the increased numbers of graduates from medical training institutions, in the recent past, Kenya still has a shortage of human resources for health, with the country ranked by WHO or the World Health Organization among the 57 HRH crisis countries in the world. So you can see we are falling in a risk that's not very favorable, because we have not, although we are training a lot of health workers, we have not been able to absorb the numbers that are required to offer the services as per the needs of the population. So the national co-health workforce density is at 15.6 per 10,000 population. This is below the target of 23 per 10,000 population. And according to the report by the report of the Kenya Harmonized Health Facility Assessment done in 2018, only about 6 countries had surpassed the global target. That's Tharaka Nithi, Nyeri, Uasin Gishu, and Nairobi. While for the majority of the countries, the health workforce density is below the target. So even in these counties where they have surpassed the targets, you'll still find the maybe skewed distribution of the workers. So you'll find some areas where the needs of the population are not being met, because you may find a good number of the health workers in the curative sector or in the higher level of service. For example, the level 5 institutions in that county. And then in the rural areas, you don't have enough workers to offer primary health care. So there are differences between counties, disparities in distribution between counties and also within counties. And maybe you can see even some of these institutions, maybe some of these counties may be having institutions that had a higher number, even before devolution, higher number of health workers. So they are still concentrated within those higher level institutions. So that's a map showing the distribution of health workers. The first one is medical officers, and the red is showing very small numbers of health workers, of medical officers in relation to the population. The green is showing relatively good numbers. I think that's for medical officers. Then the second one is for the clinical officers. It may not be very clear from the screen, but that's something you can get from the report of the Harmonized Health Facility Assessment, which is in the ministries of the site, and it's also in the, you'll find it on internet. So the other map is on nurses. So you can see the red areas also representing the areas that are very deficient, and the green, going to green, representing the areas that have better numbers. Then the other one is for the laboratory technologists, technicians, also per 10,000 population, you can see the areas that are deficient. And looking at those, you'll see there are some areas that are almost deficient in all those. In those ones, at least the ones we have picked, you'll find the areas that are deficient in medical officers, may also be deficient in clinical officers, in nurses, in laboratory technicians. So it's a problem that's affecting all the cadres in the health. So then we look at the effects of health worker shortages. And there was an opportunity to look at them in terms of aggregating them together and mentioning. But I thought trying to look at them individually would create the picture that would like anyone who is not involved in the clinical work or a health work would be able to see. So there is job satisfaction and burnout due to increased workloads for existing health workers. Reduction, and this can cause a reduction in both quality and safety of healthcare. So you have fewer workers, So those fewer workers have a lot of work to do. So they cannot be very happy with their job. So, and they get burnout. So the next thing will be the quality of the service that's being offered will not be up to standard, and the safety of care may not be very well guaranteed. Then we have healthcare services not readily accessible and increased out-of-pocket expenditures. So you can imagine a situation where you don't have enough workers. So some facilities may have to be closed because there are not enough workers to be placed in all the available facilities. So that will mean the population in those areas where the healthcare facilities have been closed are not able to access healthcare services very easily. And it means if there is maybe a faith-based facility or a private facility, they'll visit it for convenience. So that will increase the out-of-pocket expenditure for the population in those areas without the government health facility. Then we have wrong waiting times because of wrong waiting lists, crowded emergency departments, and understaffed wards and understaffed departments in the healthcare service. So, and wrong waiting times means somebody is not getting the service at the time when they need it. If you need the service today and you have presented yourself at the healthcare facility and you are asked to come back 3 months later, it means the quality of the service you are being offered is not good, and it means the service is not readily accessible. Then lack of adequate time to provide evidence-based and patient-centered care. So if we have very few health workers, they may not be, if there is a queue of 100 patients waiting to see a nurse or a clinical officer or a medical officer, it means they are under pressure to get done with that queue. So you can imagine they cannot give all the time that the patient needs, listen to all their needs, and be able to provide a patient-centered care. Also, there is the issue of evidence-based medicine, where you need to send the patient for diagnostic tests, for other tests, so that you are sure of what you are dealing with. So sometimes it's also not very possible. Maybe you don't even have lab personnel. That means you give some empirical diagnosis and treat them. So the issue of evidence-based care becomes jeopardized. So available healthcare workers may be forced to undertake tasks beyond their permitted scope of practice or inappropriate to their level of experience. So if you have very few workers, you may be telling a nurse, a clinical officer, a medical officer to do something. They may be forced to do something beyond their scope because they can see, here we have a patient, they have a need, they are suffering. But so they'll do some things that should have been done by another cadre of health worker, but they are not available. So you'll also find if you have very few healthcare workers, like maybe in the wards, and relatives or escorts or ward attendants, they'll be forced to do a lot of other work that they may not have done if they are enough healthcare workers. You find situations where you'll be asked to just screen your patient or help feed them or even help give them the medication, especially if it's being offered through the oral route. So, and generally we would not want to fail to mention of course, if there are fewer workers, it means we will have increased maternal, infant, and child mortality because we will not have enough of them to attend to mothers who come to deliver in the facilities, or mothers have no facilities to deliver in. So They will be delivered in the villages by unqualified personnel, which means there is more likelihood of maternal deaths. Infants, they come as for any service, mostly as an emergency. So you can imagine if you don't have adequate or enough healthcare workers, they'll have a lot of problems, and the mortality, infant and child mortality will increase. And then, of course, there'll be a declining immunization rates. So you'll find in some areas they'll want to put some days aside for immunization because they have a lot of other work to do because of the shortage of health workers. And of course, that one we may not see the effects immediately, but you'll see the effects of those immunizable diseases coming up later in the population because of that issue caused by the shortage of health workers. So there is also the effect of having increased length of stay in hospital, readmissions, and generally increased mortality. So if there are not enough health workers, it means the care that needs to be given in the ward is not being given or may not be given optimally. So the length of stay of the patients in the ward or in the hospital is likely to increase. Maybe their problem is not very well attended to, and you get issues of readmissions. And God forbid, even some of the times you may experience increased mortality. So there are also other matters. So our facilities in the counties, they're going to offer outreach services, and outreach services means pouring out our staff and sending them to a far off area to be able to offer a service or have a kind of a virtual health facility there to offer a service that would otherwise not have been given. So in the face of a shortage of health workers, this may not be done. Then brain drain, because of the shortage of health workers. So if you have heaped a lot of work on a health worker who is only one who is available, they are likely to feel stressed and therefore seek to move to a place where the very heavy workload would be better enumerated. Then there'll be inadequate surveillance. You can imagine where we have fewer public health officers and fewer clinical officers and even nurses who are carrying out disease surveillance, prevention, and control. If there is a shortage, that surveillance surveillance will be inadequate. Then inadequate protection of workers from work-related safety and health hazards. So if we don't have enough workers, there are areas that will not be given priority. So even the workers themselves will not have somebody to think about them in terms of what they are going through when they are going through their work. Then neglected the public health measures like inspections, health education, promotion, and increased incidences of water and foodborne diseases. So then we have the shortage of health workers can also go around and you find that we will not have enough technical professional staff or technical faculty at the training institutions to carry out some programs. So it means you might have some programs crossed because you don't have enough workers to be placed in those training institutions to execute the specific programs. Then, of course, it can't go without mentioning that if we don't have enough health workers, we'll get more quacks or unqualified healthcare workers trying to offer services to wananchi who will look for them. We'll also have an increase in unlicensed healthcare facilities because there is a need that's not being met. So somebody will put up a facility and call on the population to come for it. And then we have an accredited health training program. So you will find the institutions don't have enough nurses, so they put up courses that are purporting to be offering. They give them a name to look like they are offering. They are running nurses, but they are calling them many nurses or such names, and then they want to employ them as they would like them to be employed as nurses. So those unaccredited health training programs may flourish because somebody goes for 6 months and they are out, and you think they can offer the service to which the name is closely resembling. So addressing, I've been told my time is coming to a close. Let's look at addressing the health work shortages. So countries need to implement the recommendations of the Third Global Forum on Human Resources for Health to address the workers' shortages in era of UHC. And these ones we have looked at the recommendations. So we need increased political and technical leadership in countries to support long-term human resource development. We need the willpower, we need the commitment, we need the financing, and all these are coming from the political leadership. So we need increased political and technical leadership and their collaboration to get the systems moving. Then we need to correct reliable data and strengthening of human resources for health databases. So we need to know exactly where our health workers are, what they are doing, or what services they are offering at any one time. And that one will help to inform decisions on to do with recruitment and deployment. So this one, I think currently most of you may have come across efforts to do that. We have the National Health Workforce Accounts that's undergoing. That's a program at the WHO where there are quite a number of indicators to report on the health workforce. So in the process of correcting that information with the assistance of World Health Organization, we are able to put in our indicators which will tell us these are the number of workers you have, they are here, there are these facilities that are not being manned. So we are able to advise the political system and the policy making level on recruitment and deployment of the health workforce. Then maximizing the mid-level and community health workers to make frontline health services more accessible and acceptable. Detention of health workers in the countries where deficits are most acute and greater. Balancing of the distribution of health workers geographically. And then providing mechanisms for the voice, rights, and responsibilities of health workers in the development and implementation of policies towards and strategies towards universal health coverage. So we need to, in order to address the shortages, to address the brain drain and the migration, we need to involve the workers in decision making and in policy making and in the responsibilities that we give them. Then we briefly look at the strategies for restoring the healthcare workforce. We need to promote public health and preventative measures. So this one we have always said, and we need to go back to primary healthcare. If we do that, we'll actually need arena workforce at the curative level where we have the hospitals and the health centers. Attract and retain more health workers to primary healthcare roles. So we know that the primary healthcare roles are may not be very attractive to a good number of the workers because it's mostly, you'll find it extending to the rural and hard to reach areas. So you need to get strategies to devise mechanisms to retain them there and keep them happy to provide services. Then provide online healthcare training and capacity building. So this one we have seen is very possible during the COVID COVID-19 pandemic, and we only need to prepare appropriate curriculum for that kind of training. Increase policy initiatives aimed at supporting human resource development. So that cannot be overemphasized. We need to look at all policies to see that they are encouraging, they are supporting human resources for health. Collecting comprehensive, high quality data for the health databases. That one we have said, and we are making efforts in correcting those databases. Then giving healthcare workers a voice in shaping registration and policies, like we have said on the recommendations of that global forum. Then finally implement the WHO, World Health Organization Global Code of Practice on the international recruitment of health personnel. So this one is arising as a result of the agreement that has been reached between, like, for example, the government of Kenya and the UK government on movement, migration of health workers or employment of health workers in the UK. But although this is not where it's beginning, it has been there. But we need to invoke or implement the global code of practice, where it talks about the welfare of the workers when they go to that country, and who you can take from here, and what numbers you can take, and what numbers you can't take. So it's a very important document, and there are efforts at the moment to domesticate that document to enable our workers who are not employed, or those who would like to go there safely and knowing that they are supported by some framework. I think that's my last slide. So thank you very much for your attention.
Thank you, Dr. for that elaborate presentation. You realize in the program he has scaffold 2. That is why I was a little bit patient, because I realized that he has scaffold 2 at the same time. Next, we will now move to staff welfare and motivation, whereby will be taken through by Dr. Lucas Nyambero. Dr. Lucas Nyambero. Yes. Then do we have that person who is making that presentation? Then Peter should be also preparing the next presentation about salary payment and third-party deductions, as well as Moses Chando. I had stated earlier, there is a slight change in the program. Maybe for those who came a little bit late, there are some things that we have interchanged. There are some presentations that we are to be made in the morning, but we have taken them in the afternoon. So that is why maybe you realize that what I'm reading might not be directly, corresponding with the hard copy that we have. So there are some slight changes. And what Dr. Kihama has presented, you realize that is what is actually happening on the ground. The issue of HRH cannot, we cannot, I mean, it is the main problem that we are having in almost all the counties and even in at the national government. That is a component that if it is not addressed, we cannot talk of success of UHC, because without human resource, therefore, we cannot be able to provide quality services. So, I think we can go to the next presentation, Peter Karewa, about third-party deductions. I know you are here. And as he winds up, Mr. Moses Chando Pia, be ready. A round of applause.
Good morning. My names are Moses Chando. I think there's just mix up. I'll be doing a presentation on behalf of Peter. So my presentation is about salary payment and third-party remittance. Oh, thank you. From the definition, you'll find that remittance is the amount paid or transferred from the employer to a third party. And this third party, either union, the KRA, NSSF, among others. So according to the labor law, section 19(1) of the Employment Act, an employer is allowed to deduct statutory deductions from the employee's salary and remit this to the third parties. And it's worth noting that before you deduct, the employee must agree. So an employer cannot just start deducting something from your salary without you agreeing to it. But we know that there are some mandatory deductions. For example, union, you cannot just deduct my salary and pay the union if I don't subscribe to that union. Next slide. These are some of the statutory deductions. We have KRA, NHIF, NSSF. Next. Some of the deductions, we have union dues. Now, if you deduct salary, my salary, to pay the union, and then you don't remit this, how do you want the union to sing solidarity forever? So once you've deducted, you have to remit, even the SACCO dues. Next. County situations, you'll find that most of the counties have not been remitting these statutory deductions. We have a case of Embu, Meru, Muranga. They were taken to court. And as we speak, I'm told that the county secretary cannot be in the office, because they secured warrant of arrest. So, next slide. We have a report which was published in August stating that Siaya government owed several institutions more than 320 million in statutory deduction. City Hall, Nairobi Metropolitan Services owe 490 million in statutory deductions. That was by 2021. So the effect, when you deduct this money, when you delay with health worker salaries, what are the effects to the healthcare worker? One, The healthcare worker will be denied credit facilities by financial institutions, e.g. banks and loan. Someone told me that he went to the ATM to withdraw. And then he's like, alikuwa anafikiria ATM inamwambia toka hapa because anajua you've not been paid. So out of pocket payment for healthcare workers, you've deducted my money. I've subscribed maybe to health insurance. You deduct, you don't pay. My child is sick. I go to the hospital. I'm being denied service. Yet my money was deducted. And I'm forced to pay out of pocket. So another one is reduced morale to healthcare workers at workplace. Next slide. Now, the effect now to the employer. If you don't remit, you delay with the salary. Oh, I'm forgetting. Huh? Even not Siaya, Homa Bay County, they just paid the salary just the other day on Monday, this Monday. After several strikes, several go slow by the healthcare workers, they received their salary just the other day, this Monday. Now, the effect to the employer, we will have constant strike. The output of this healthcare worker will be reduced, hence service delivery will be compromised. Litigations, for the case of Embu, Muranga, and as we speak, the county secretary is a wanted man. So it also affects the mental health of these healthcare workers. You'll find a healthcare worker walking and talking to himself or herself because at home, there's nothing. At work, he's also expecting nothing. Time wasted at workplace. A minute lost by a healthcare worker means a life. Life might be lost. So now, some of the recommendation, it's a legal requirement by the employer, including county government, to pay healthcare worker salary on time and remit all these deductions from the employee salary within the time period. All the counties to establish a work council. This is a dialogue platform where the employer, that is the county health management team, and the union officials sit together and discuss. Next. What are you seeing? Healthcare workers on the street. They are trying to fence their village. Yes? We are saying that if you want to break record, you try to fence your village. Nobody has ever fenced their village. So we are really trying to fence our village by carrying placards. So we need to move from this, next slide, to this, whereby we can sit down, talk, and agree. If we have a demand as employees, we will tell you that this is our bare minimum. And then as an employer, you will also say, yes, we can do A, B, C, D, but D next time. Thank you.
Thank you, Peter. Last slide. You want to watch the last slide? Okay. Thank you, Moses. I think that is the situation on the ground. You saw in the headline recently, a warrant of arrest against governor, the CS, and the chief officer finance. That is the account where I come from. That is account where I come from, whereby the county decided not to deduct money from the health workers from August, I think 2020, not 2020, 2019. And now the county is required to pay from their kitty, all the unions, not one union. So these are the issues that are really, really, really affecting the workers on the ground, and not only union deductions. You find that there are some counties whereby even you cannot access even 20,000 shillings and funds because your loan is in arrears in the excesses of 6 months. And that money has been deducted because that person that does not have a loan gets the money in full. So those are actually issues that if the health workers are to work properly and are to be motivated, I think they have to be addressed. Because when you find that the health service providers, they cannot access the same services that they are providing, it is not easy. When you find that you are offering health services, but you cannot be treated because your NHIF has not been updated for the last 6 months, it is a pity. So thank you for those presentations. I don't know whether the presentation that we have skipped, the presenter is with us about impact of Dr. Nyambero is. So I think we will go to the next item. I need to be guided to chair if tea is ready, because if the presentation is yeah, because in the next item in the agenda, in the absence of that presentation, is tea. Thank you. Yeah, I was seeking for that that guidance. So we'll break for 15 minutes so that we can come for online presentations. I understand there are some presentations we meant online. So to allow the presenters to forward their presentations, so we can take a 15 minutes break, then we reassemble so that we can proceed with the program. Thank you once again. I'm told we pray for tea. Let us pray. Bless us, O Lord, and this your gift, which you are about to receive from your body, through Christ our Lord.